Hello, everybody. Welcome to the next surgery of DLDR. At this current time, we are experiencing a little bit of audio technical difficulties, so we may be having a Q&A, but we shall figure it out as we go.
Comment.
Yeah, stick it on. Perfect. That's good.
Beautiful.
And then try to put the transmitter in my left pocket. Just reach around through my collar. Reach around here. It's got to go over my shoulder. And then into the breast pocket. It should be right around there. All right. Welcome to our live stream. I'm Dr. Duke Majan. Did you get an AP? Oh, that's good. You feel it?
Yep.
We in?
It's in.
Nice work. All right, maybe fix the one on my right ear. It's squeezing my right ear. Lift it a little higher. There you go. And then the same thing on the left ear. It's a little bit on my face over here. There you go. Perfect. All right. Okay. Well, I gowned without my microphone, but my team, Oscar, has successfully put it on me. We're going to be doing the L5-S1. I don't know, Jordan, you're holding the down too long, and you're just getting a beginning cine, and that's why it's so bad. Please let go sooner. Shot. We're going after L5-S1 today in this patient. Shot. She has a herniated disc at 5-1, and her pain is right there at the L5-S1 region. All right, that's looking pretty good. So let's get an AP. You can see on the x-ray that we're at L5-S1. I'll have Jordan show you the sacrum in a moment. And again, I don't know if she's moving, probably, but there's some WAG issues. All right, there we go. That's pretty good. You can see her spine has scoliosis. A lot of people say, how do you fix back pain if you're not fixing the scoliosis? The answer is, you don't need to fix the scoliosis. The only way to fix scoliosis is to do a fusion. And that's a osteotomy infusion. Shot? All right. We're making some good progress. Want to get a little bit more medial on her. There's the facet. Need to go around it and stay medial. Shot? All right. Good. I feel the herniation. She awake? Close?
Okay, open your eyes for me. You're doing well. Open your eyes. I'm going to ask you a few questions, okay? I'm going to ask you a couple questions. Dr. Duke wants to ask you a few questions.
All right. How long has she had back pain for?
How long have you had back pain for? Please, don't move your arms. How long? How many years? How many? How many? 10?
10 years.
10 years, okay.
All right. So she's having pain right here in her back. And we got the MRI, which showed an annular tear and a small herniation. Are you comfortable? Yes?
Yes, you said yes.
All right. Are you ready?
Yes.
You having any pain?
Said no.
How bad is that on a scale of 1 to 10? How high did it go? I heard her say
7.
7. Is that where you typically get back pain?
Is that the area? Yes.
7. The highest that one was 7, or did it go higher? I thought she said 10.
Did you say 7 or 10?
What's the highest that went?
The highest. Can you hear me? What number? Well, yeah, what number? 0 to 10.
I heard 10.
Yeah.
So we're going to do 7 to 10. We'll just say 7 to 10. So it's somewhere in there. And we're ready to go to sleep. So, Jordan, can you show us on the x-ray? Oh, on the other x-ray where the tear was, which is now kind of gone, but you could actually see it in the back of the disc. She definitely has an annular tear. That's where her pain's coming from at L5-S1. Shot? Mm-hmm. Can we do a quick AP? We're going to make our incision, 7 millimeters, to do this endoscopic spine surgery. Shot. All right. Here we go. Looks good. Go back to a lateral view. This is a relatively bloodless surgery. We're literally going to lose a few drops of blood, that's all. I'm going to use a dilator to go down. And the dilator, the dilator has a pointed tip. It doesn't cut anything. It literally spreads the tissues. Now, what a lot of people don't know is that most of your body's tissues, not all, but most, they're fibrous. They're fibers, okay? Have you heard of muscle fibers? Have you heard of nerve fibers? And of course you have fascial fibers, fibers of fascia, which is the soft tissues. So most of our body has fibers that allow this thing like this dilator here to pass through them and will not do any damage. Basically the fibers just collapse back around once we take these things out. They just come back together. Shot? Yeah. Grab it out. Yep. Shot? We are in the L5-S1 disc at this point. We went through a tear that's already there. We didn't have to take any bones or ligaments out. We literally used the natural hole that's already there. Man, yeah. That's it. That went in pretty easy, huh? Really didn't take a lot of effort to get it in. That means the tear is big. She knew exactly where her pain was coming from. She came and told me, I have pain from my L5-S1. I like when patients do that. They make my job easier. And I looked at her MRI and I looked at her on exam and I said, you're right, I think it is coming from L5-S1. Well, now we've just confirmed that. I'll take care of that.
Yeah, I need to remove my glove too. Because I pinched my glove, you see?
Pinche?
Yeah.
You double glove, right?
Yeah.
We're good. Scope on. Let me just look. Yeah. Yep. Laser.
We have a couple questions.
Yeah. Sorry. I've been a bad host. I'm just been focused on this surgery, so we will take questions. Absolutely.
All good. This first one comes from Oz on YouTube.
Uh-huh.
They ask, is there any medical rule or standard requiring injections or PT before doing any surgery?
Is there any medical rule that requires injections to be done or PT to be done before surgery?
Correct.
The answer is yes and no. So is there any rule among patients and doctors? No. But is there the insurance companies, do they force patients to do treatments like physical therapy first before they'll cover surgery? Yeah, a lot of them will. Now I'll tell you this, physical therapy doesn't work for disc problems. It never has, and it never will. A disc injury is a disc injury, and disc injuries, well, unless you're fixing the disc is going to continue to hurt. It's going to continue to be painful. So you have to treat the actual source of pain, which is the disc. Physical therapy doesn't do that. Physical therapy fixes muscles if you have a bad muscle problem. And it used to be believed that muscles were the most common cause of chronic back pain, but they're not. Muscles never cause chronic back pain. It's not true that they cause chronic back pain. Muscles hurt because joints underneath the muscles are hurting. And if you don't fix the joints that are damaged and painful, you're never going to get rid of the pain. So therapy can't fix joints. Pain pills can't fix joints. Only surgery can fix a joint that's damaged. That's the truth, the God's honest truth. So why do insurance companies do that? Well, the reason is simple. Most people can't afford to take time off of work to go to therapy 3 days a week. Or they can't afford to make all the copays for therapy. Because if you ever gone to therapy, you know you have to pay 50, 60 bucks or more every time you go. And it doesn't work. So what happens is people don't do it. And then the insurance company says, oh, hey, you didn't do it, so we're not paying for your surgery. It gives them a way to get out of it. When in reality, they should be paying for the surgery because surgery is necessary. But it's kind of a trick they play with you guys to get out of paying for spine surgery, where they say, hey, since you didn't do the therapy, you were bad. You didn't do the therapy, we're not going to pay for your spine surgery. And then the patients feel guilty, like, oh, shoot, you know, it's my fault. But it's not your fault. Because you're right, therapy doesn't work. And we definitely recommend therapy, but for muscle problems, not for a bad disc that's hurting. Okay? There's a lot of deception, unfortunately, in this field, in spine. There's a lot of bad surgeries being done, a lot of bad treatment being done. And if you want to talk about medically unnecessary care, doing physical therapy for a bad disc, that's medically unnecessary care. It's never going to fix the pain from the bad disc, ever. So if you want to fix disc pain, you have to do disc surgery. Therapy will never do that. The only thing that can happen from therapy is therapy can actually like make you wait 6 weeks, and guess what? When you wait 6 weeks, the disc pain gets better. But it's never going to go away. It's never going to go away. And it's never going to go away because therapy cannot make disc pain go away. It's a damaged disc. And therapy doesn't fix damaged joints. So, but the inflammation will get better, and you might feel better, and then you said, oh, therapy worked. But therapy never worked. You just got better on your own. So there's a lot of nonsense that happens in spine, unfortunately. And I can't stop it from happening. I can only inform you guys about it. And then you guys got to stop it from happening.
We have another question.
Sure.
This comes from JMC on YouTube.
Almost done. 1 minute.
They asked, is it just me or is robots for spine surgery useless? Everyone that I know that have had surgery using spine robots, the screws broke.
Yep, you're right. Whoever said that, you are correct. Robots, and I've said this before, total unnecessary waste. But here's the problem, my friend. You see, healthcare has become extremely, what do you call it? Corrupted by venture capital. And venture capitalists, well, they want something physical to sell. They want to invest in something like physical. And spine robots are a great trick to get people to invest their money. So a company comes in and creates a spine robot, right? And the spine robot's garbage. It doesn't really do anything. But if you hype it up and you get enough doctors using it, and then you have some sales, few million bucks, then you go out and say, look, spine robots, we've got 5,000 hospitals that need them, and 50 of them bought it for $1 million, so we made 50 million bucks. But if we had some venture capital money, we could make even more. And that's what happens. And people invest in the spine robot company. And then, of course, the sales never really happen because this thing is a piece of junk. It doesn't do anything, but it's all hyped up by these doctors. All right. We're done.
All right, lights on, please. Jordan.
That was tough to get into. So I agree with you. You're not imagining things. The spine robot, I think, is completely useless. We've been doing spine surgery for years just fine without robots. What happened? You got it? You okay? I need another needle. I don't know that I can do it through here. Well, let me try it, Louis. I think we're okay. Let me have a little more irrigation. Feel free to type your questions up and I'll answer them for you. Yeah, we're already done because this was a single level 5-1. I would never buy a spine robot. It's just a gimmick, and it's just a financial play in the world of medicine where these companies are basically just selling shares in their robots and making billions of dollars in profits. And then the whole floor is going to fall out because there's really no reason to have a robot. Robots were originally created for the purpose of, like, let's say you had soldiers in Iraq and there was no surgeon out there, but you had but you had a you had a robot like Da Vinci, and you had a surgeon in New York, and the soldier who got hurt could come into the operating room with a robot, and they could do the whole surgery using a robot to take out like a bullet, or if they had a ruptured appendix or gallbladder, and you could save a soldier's life because there was no surgeon there. But they could have a whole line of soldiers coming in, one surgery after the other after the other. They could just change out the staff, the nurses, the assistants, the technicians, and they could literally run an operating suite all night long doing surgery on soldiers in a far-off place that's dangerous where there's no surgeon, but the surgeon could do the surgery remotely. But when it comes to spine surgery, it's really, in my opinion, too delicate, There's too much touch and feel that you need to really feel. And yes, the robots are designed to give back, this haptic sensation, feeling, but I think they're completely unnecessary. And the problem is they rely on navigational data that's fed into the system, into the computer, but that data can become corrupted and unreliable if the patient's body moves. Okay, because what happens is they take a CAT scan or an MRI in an MRI machine before surgery, feed that data into the robot, and then the patient gets positioned on the operating table and their spine moves from where they originally had the MRI or CAT scan, and it's in a different position, right? But they register let's say the sacrum with the robot navigational platform, and then the L4 is actually moved now 5 millimeters from the original MRI that was taken, because the positioning on the operating table is different. It's a different position of the spine from when the MRI was taken at the time of surgery. And so now that navigational information is inaccurate, and the screw will be misplaced because the spine at L4 is not where, in the operating room, is not in the same place it was during the MRI. That's the downside. So the way they've tried to counter that is by doing intraoperative CT scans, where they're actually getting a CAT scan in the operating room after the patient's position, and then they feed that registration data into the robot and the navigational system, and that's more accurate. And it's true, it is more accurate, but the spine still moves with respirations and stuff. So the best way to do it is to use real-time information with an x-ray and a skilled surgeon. But the problem is there's a lot of non-skilled surgeons out there doing spine surgery who really are terrible. So the robot will make those people better. But honestly, we shouldn't be going to those surgeons anyway, because they have such a high complication rate to begin with. So it's a complicated topic, but I personally don't advocate for spine robots. I think it's just a big pump and dump, venture capital, PE play, which we see so much of in healthcare now. But let me go ahead and type up the rest of your questions. I'll come answer them for you, okay? And good morning, I'm Dr. Duke Majan. I'm here with one of my lovely patients from Canada who has visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L5-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada, who then said, yeah, I'll have you see the specialist in 3.5 years. Yes. Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Duke Spine Institute and learned about the Duke laser disc repair endoscopic surgery. And you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, this is the happiest I've been in a very long time to be able to stand up straight and go for a walk. Because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful also to be able to do what I want to for the rest of my life.
Yeah, after we let the disc heal, right?
Yes, full year of nothing, and then we can.
Yeah, I wouldn't say nothing, but horseback riding, it's one of those things where I love horses and I love riding horses. I'm not very good at it, but I'm one of those people you see bouncing up and down, up in the saddle. So I know that it can be rough on your back, and I just want to make sure you give your back a full year to heal. So you can see in your surgery right here, we actually tested your L5-S1 disc with a discogram, which is a test done to verify that that disc is indeed causing your back pain. And when we tested it, you said, and we asked you how bad it was, you said 10 out of 10 pain. And I said, is that your typical pain you get every day? And you said, yes, it is. So we verified the source of your pain was the L5-S1, and you can see the laser was used to clean the tear endoscopically. Your incision was only a 1/4 inch, and there's no need for fusion or metal or artificial discs. This surgery replaces fusion and artificial discs. What are you going to do now that you're feeling better?
Well, it's, again, don't worry, I will take it easy, I promise. But no, I'm gonna be, after this, this year, I hope to be the strongest I've ever been, and I have very high hopes and whatnot. My dream is to make actually the Canadian Olympic team for my sport, and that's end goal, and I feel like it's a possibility now.
Absolutely.
To do it.
You can.
Yeah.
We're rooting for you.
Mm-hmm.
And I know you have an incredibly supportive husband who's been by your side the whole time. He's a delightful young man, and I've had time to talk to him as well. So you're lucky you have support from your family to help you get through this.
Yeah.
Anything you want to say to your fans out there?
Oh, geez, I don't even know where to start other than just this place really can offer you really what either you deserve or what you need going forward to be able to live a happy and good life. And it's amazing to me that literally it was yesterday I woke up from it and I went for a short walk like immediately, and I felt amazing. So it's it's very hopeful, and if there's you are suffering from any of it, don't wait, especially for the Canadian system. Come and do this. It's worth it. It's really worth it.
Awesome. And I'm going to be, and my whole team is going to be watching the equestrian sports and the Olympics, looking to see for you to be there.
Yes.
All right.
Awesome.
And
Amazing.
of course, supporting you.
Thank you. Yeah.
All right. Congratulations.
Thank you so much. Thank you.
All right. Take care. All right. Well, we've heard from one of our patients who underwent the Duke laser disc repair and had a great result. Hopefully this patient will as well. She was a single level L5-S1. When she came to me and said, hey, my pain's like right here in my back, in the low back above the butt crack, I think it's L5-S1. I said, I think you're right. So we just confirmed that. We did a discogram, and indeed the discogram was painful for her, which means that disc was causing her pain. Normally, if a disc is not a painful disc and you do a discogram, it will not cause pain at all. So the fact that it caused 7 to 10 out of pain, we couldn't really tell what she said, but it was somewhere between 7 and 10. I heard 10, Louise heard 10, Dr. Berndes wasn't sure what he heard, but long story short, it was her typical pain that you get, so I feel good about it. Her spine definitely has a lot of scoliosis. You could see it on the x-ray. It's twisted. It was kind of twisted off away from where we were, off to the left side. I feel pretty good about the surgery. You know, I feel like we got enough of that herniation out that we're going to be okay, but we'll see. Any questions we have?
Yes, this first one comes from Oz on YouTube.
Hi, Oz.
And they ask, can osteophytes be caused acutely from trauma?
Can osteophytes be caused acutely from trauma?
Correct.
100% no. Osteophytes take a long time to grow, years and years to make osteophytes. They're never caused by acute trauma.
Next question comes from Matt on YouTube. And they ask, hello, I understand you don't remove all the herniation, but when you do know you have gotten I understand you don't remove a lot of herniation, all the herniation, but when you do you know you have gotten a sufficient amount of the herniation?
Matt, great question. Yeah, so you know, you're asking a wonderful question. There's no way for me to see the whole herniation ever, except in the cervical spine. But in the thoracic and lumbars, because we're coming from the back side, we're kind of pointing this way like at an angle, it's harder to tell if we've got it all. But the scope gives us a pretty good view. And really, I like to say this a lot because it's true, the proof's in the pudding, it works. And the system we use and the way I've done it now for 17 years is very consistent. It's the same way over and over again. And basically what I do is I use the tube and I try to angle it as medial as I can towards the herniation in the back of the disc. and I just use that laser and clean out as much as I can until you can see the epidural space. And you're really limited by the facet joint. That's what's going to limit us in this procedure, just so you understand what I'm talking about. Everybody see the spine. This is the facet joint right here. A lot of people, the facet joint gets big over time. It enlarges from arthritis. So I'm coming in from the side and I'm hitting the joint, sliding around, going into the disc, right? But what limits my ability to go more towards the midline, medially we call it, is this facet joint. I'm banging against it. And everybody's facet joint's different. Some people have a bigger one, some people have a smaller, some people have a more medial facet, some people have a more lateral facet. But if the facet joint is really lateral and really big, it really blocks me from getting medially on the disc herniation. That said, we've had a really good run of luck. I mean, even on those cases where I'm not that happy about, like this one in particular as well, there we've had great relief of pain. And after all, that's why the patients are coming. They want to get rid of their back pain. So we'll see. We'll see how she does. One thing I could do in her case in particular, which I'm going to talk to her about afterwards, is if I didn't get enough of the herniation, I would come from the other side, the left side, because the spine is twisted off to the left side. I may be able to get some more of that herniation from the left. And so that is a consideration that you can do. You can go from the opposite side. Great question.
Last but not least, we have another question from Oz, once more on YouTube, and they asked, what do you think about orthopedic tests like straight leg tests, Hoover tests, Sperling tests, and are they reasonably accurate?
You know, Oz, great question. I mean, I grew up being trained to do all these orthopedic tests like you're talking about, looking for pinched nerves. But look, here's the thing. You've got to separate in your head. There's two things. Every patient I look at, there's two things I'm looking at, okay? I'm looking at back pain and I'm looking at leg symptoms, and they're completely different. What causes back pain is inflammation in the tear in the back of the disc, if it's coming from the disc. What causes leg symptoms is inflammation of the nerve root or pressure on the nerve root, so one or the other. So the straight leg raise test is a test for a pinched nerve, right? Sperling's is a test for a pinched nerve in the neck. Pinched nerves are not everything. A lot of people care about pinched nerves. I'm going to fix the pinched nerve, obviously, by getting the pressure off of it. But what a lot of people care about is their back pain. Like this patient, she didn't really have any pinched nerve symptoms. It was all back pain. So we get a lot of people like that, just neck pain, just back pain, and it's not the Sperlings or the straight leg raise that's important for these people. It's understanding that the back pain is coming from a structure, being able to identify that structure before surgery based on the anatomical location of the pain, plus the MRI findings and my experience, and then drawing upon those to diagnose the source of the pain. Once you've identified the actual pain source, all right, it's the L4-5, it's the L5-S1, it's the L3-4, it's on the right, it's on the left, it's on both. Once you've done that successfully, then the treatment it's a no-brainer. You just do the laser surgery for disc pain, you do the Duke plasma rhizotomy for facet joint pain. So in her case, and in a lot of people's case, the straight leg raise test is not important. I don't really even pay attention to it, to be honest with you. I listen to the patient. Patient comes in and says, I got back pain here, and it goes down my leg to my toes. I go look at the MRI. I'm thinking down my leg to my toes has got to be L5, L4, L5-S1 nerve root. So I'm looking at a herniation at L4-5, L5-S1, or maybe L3-4 at worst case. So I'm looking for that. And when I see it, that herniation and that stenosis, I know that has to be treated. So the straight leg raise, not that important. There's a lot of historical information, not that important. Of course, we're all taught that when we're in training, but the reality is it's quite simple. I just want to know, do you have back pain? Do you have leg pain? How far down your leg does it go? Does it go down the back? Does it go around the front? If it goes around the front, you're looking at a higher nerve root, like L2, L3. If it goes down the back, of your leg all the way to your foot, you're looking at L4, L5-S1. So I use that information. That's important. I like to look at dermatomes. Where is the numbness? Where is the weakness? Myotomes. And reflexes are not that helpful to me, but the straight leg raise, the Sperlings, I could do without them, honestly. And I could diagnose people just fine and fix them just fine without them.
Next question, two more questions. This next one comes from Matt on YouTube, and they ask, also, while the disc is healing, what is taking its place, if anything? Or is it just taking the herniation off the disc?
Yeah, so getting the herniation of the nucleus out of there allows the annulus to seal. You saw some annulus in there when we were in there. That white stuff is all annulus, and it looked pretty good. I think it's going to heal fine. Like I said, because her spine is twisted away from the right side pretty significantly, and that facet joint gave me a little bit of a hard time trying to get medial. I do want to see how she does, and if she's still having any pain at 5-1, I would repeat the surgery from the left side, the opposite side. But that said, I think we got enough of the disc out. The annulus will heal. It wants to heal. The only reason it's not healing is because of the herniation and the scar tissue that's there. So I cleaned out what I could of the herniation and the scar tissue, and the rest is going to be up to her to heal properly. So.
And then last but not least, from Seriously on YouTube, they ask, is a disc a joint?
Yeah, seriously, hi. The disc is definitely a joint. Absolutely, 100%. It is not a true diarthrodial joint, which is a joint that has cartilage on the surface of both bones and a synovial membrane and capsule and synovial fluid. It doesn't have those features, but it's still a joint. A joint is any place where two bones come together and move, and the disc is a very important joint. Matter of fact, the most important joint in your spine, and it's the #1 cause for back and neck pain about 90% of the time.
And that's it for questions.
All right, well, I hope you enjoyed the surgery, and we'll be back possibly for one more, a Duke plasma rhizotomy. It's a bilateral L4-5, L5-S1 facet joint problem. This patient has pain in his facet joints, not the disc. This is the facet joint. You can see the facet joints move like a joint as well as the disc, and his pain is coming from these joints, L4-5, L5-S1, both sides. I'm going to go in and do a Duke plasma rhizotomy. I'm going to burn the medial branch of the dorsal ramus there, and there at L4-5 and S1. So that will get rid of his facet joint pain permanently. This is a new technology developed at Duke Spine, only available here, and it gives permanent relief, where the RFA, radiofrequency ablation, you've all heard about, is temporary. Duke plasma rhizotomy is permanent.